We move on to the next oration, that's Taradevi Memorial Oration. This year, this has been conferred on Professor P.V.Manoria, past President, Cardiological Society of India, and Chairman, Manoria Heart and Critical Care Hospital in Bhopal, Madhya Pradesh. For the next 12 minutes, Professor Manoria would be deliberating on PCSK9 inhibitors. Are we heading for a new revolution after statin therapy? I'd like to invite Dr. C.M. Khanna, Manjumani, Ashish Contractor, Priya Jagia, Sandhya Shankar, and Anita Rani Kansal.
Ladies and gentlemen, this is also a very important session, Tara Devi Memorial Oration, being bestowed upon none other than Dr. P.C. Manoria, who needs no introduction to the audience, a past president of CSI and a very prolific speaker and a prolific academician. The topic is going to cover is PCSK9 inhibitors. Are we heading for a new revolution after statin therapy? Ladies and gentlemen, I present to you Dr. Manoria.
Thank you, Dr. Chopra. For the next 12 minutes or so, I'll be talking on this very interesting topic, PCSK9 inhibitors. Are we heading for a new revolution after statin therapy? All of us know dyslipidemia is a major modifiable and most common cause for atherosclerotic disease. We also know that 50% of atherogenic risk or coronary heart disease is contributed by dyslipidemia. And one very simple thing you must remember is that it is only the ApoB which enters the vessel wall for atherosclerosis. Whatever circulates in the blood for atherogenesis, it has to go via the ApoB. So research in dyslipidemia continues unabated, and we have newer and newer agents. But amongst these, it's only statins which has lengthened the lives. Ezetimibe did show reduction in cardiovascular events, but remember, this was only on top of moderate statins and not high-intensity statins. So there's still a question mark on ezetimibe. But it is 2015 which came with a breaking news when two PCSK9 inhibitors, alirocumab and evolocumab, were approved for clinical use, and with this, a new era of PCSK9 has erupted. We have already seen the statin era for the last 25 years, and indeed, statins have emerged as CV risk-reducing agents. Interestingly, when both these agents are combined together, they decrease LDL to super low levels, even up to 25 in substantial number of patients. Therefore, two questions automatically erupt out of this. Number one, is super low LDL safe? Because there are a lot of concerns about this. And you can see this data from the Osler trial, less than 25 and more than 40. No difference in the incidence of side effects. In fact, some of the numbers are less in LDL, less than 25. We have also data from the Odyssey long-term, again, alirocumab and LDL less than 25. No difference in the side effects. You can see some of the numbers are even less, 3.7, less than 0.58, 4.2. Some of the numbers are less in LDL, and we have case reports of loss of function mutation. LDL is 1,4, and these patients are leading a healthy and fertile life. So the first question is very well answered. The second question is, does it have the potential to further decrease the cardiovascular events on top of statins? And again, the answer is yes. Look at the separation of the curves, a 53% reduction, but this is not sufficient. What it has done is that the curves have started separating merely after a lapse of 60 days, which is virtually impossible for any other drug on top of high-dose intestine. So curves separating 60 days, usually, as we said, in secondary prevention, takes a lot of time. And look at the other trial, Odyssey long term, again 48% reduction. And look at both these trials together, both have shown reduction in events, but the problem was the number of events are less. And although the FDA and ESC has approved, this finding is now being confirmed in 3 mega trials: the Fourier with evolocumab, the Odyssey outcome with elaricumab, and the Spire with boxazumab. In the statin era, the dicta was LDL lower is better. In the PCSK9, the dicta may be super low LDL, may be lower, may still be better, and the reason being it is LDL which constitutes 90% of ApoB. So if you modulate LDL, if it is safe, events would decrease. So the next question arises, what is this PCSK9? And in very simplistic terms, this is PCSK9. This curly thing is LDL receptor, and this is the LDL particle. The normal function of LDL receptor is hepatic clearance of cholesterol, and it is a very important function. It takes the LDL particles inside the cells, they are metabolized, and LDL is cleared. The normal function of PCSK9 is to produce lysosomal degradation of the LDL receptor. This is PCSK9, it has come, the receptor is degraded, cannot be recycled. Each LDL receptor can recycle up to 150 times. So degradation of one LDL receptor is very, very important. Now imagine if there is gain of function mutation of PCSK9. PCSK9 is more active. What will happen? Large number of LDL receptors will be degraded, the number will decrease, less cholesterol cleared, and increase atherogenicity. But imagine if there is loss of function mutation, or you block this PCSK9 with monoclonal antibodies, the PCSK9 will become dysfunctional. The LDL receptor will be free to carry out its function of clearing LDL from the liver, getting recycled again and again, and there will be marked decrease in LDL, decrease in atherogenicity, and decrease in the cardiovascular events as I have shown you. Now this is the data on evolocumab. The drug is already approved and is available as 140 milligram in 1 ml pen. It was tested in the Profocio Global Program, 14 trials, all of them have been completed. This is data on elaricumab. It was tested in the Odyssey Global, 23,500 patients, but is already approved, commercially available as 1 ml pen, 75 and 150. And this is boxazumab being tried, not yet approved in the Spire 1 and 2. So PCSK9 has emerged as a new star on the lipid management scenario. Why? Because it consistently decreases LDL by 50 to 70% on top of statins, and large number of patients will achieve LDL goals. And what is very interesting for the Indians is that LPA, which is troublesome, we don't have any effective drugs, is decreased by 25%, and there is a favorable trend in all other lipoproteins. Side effects, minimum, some nasopharyngitis, electric reactions, backache, and safety is good. And it has been approved from these subset of indications. For statin intolerance, in a real patient, it has proved to be a boon. Familial hyperlipidemia is a boon. Most of these patients die of precocious cardiovascular disease in spite of statin, ezetimibe, LDL epetrases, mipomycin, and lomeglutide. And very high-risk CVD patients, not LDL goals, not repeatedly getting angioplasty, repeatedly getting surgery. We have seen some sort of patient, LPA elevated, this may be a good drug. And these preparations are available commercially, but there are several unanswered questions. The first question is, will LDL lowering with PCSK9 follow similar or better patterns than statins? The smaller trials have shown a favorable stand, but if we presume that they will, then we will be able to reduce the lipid risk as an atherogenic risk by 45 to 50%, and we know lipid contributes 50% patients of coronary heart disease, and that will be a very great day to rejoice. Because of the wonderful effects of PCSK9, now a tussle is started. Which should be the best strategy for inhibiting PCSK9? Antibodies to PCSK9, I have shown you the data, is at the present commercially available and still being evaluated, but attempts are now being made to inhibit synthesis of PCSK9 and these short peptides which prevent the attaching of the PCSK9 to the LDL receptors, but at the moment it is monoclonal antibodies. So PCSK9 inhibitors have initiated dawn of a new era. There is no compound on the planet that has ever demonstrated so much hope, and you must have seen in all international conferences the coverage of this molecule, and it is speculated that this may be the next wonder drug after statins, and we are heading for another revolution after statin therapy, and will be able to minimize the atherogenic risk due to dyslipidemia, which is nearly 50%. Dyslipidemia has undergone a revolutionary change. Cost, of course, is a limiting thing. When we were students in 60s, the lecture on dyslipidemia used to be given by professor of biochemistry. We still remember him, and this was the scenario by the end of the lecture. But today, when lecture on dyslipidemia is given, there's a lot of questions, lot of queries, lot of comments, and even the speaker, after delivering the lecture, keeps on thinking, because every time a lecture is given on dyslipidemia, there are newer issues. Thank you very much for the attention.
Ladies and gentlemen, I think the data which is shown by Dr. Manoria is a mind-boggling, and he's taking us to a new dimension as to how to manage our patient with dyslipidemia. Let's give a big hand, and I think it's open for discussion, interaction. Since it's an oration, we will not be able to have any discussion. I'll request Dr. Naveen and Dr. Salvamurthy to please join me to give you the token of appreciation to Dr. Manoria. Please, Dr. Manoria. Jagya, please come forward. Dr. C.M. Khanna. Jagya, where is Jagya? Please, don't stay back. C.M. Khanna also. Come here, come here. Come in front. He feels happy when lady puts a good medal. Yeah, put it.
Very good talk. Really good.
Thank you very much, Jagya, to give the token of this to him. Thank you, Dr. Manoria.